A very good afternoon, everyone, and a warm welcome to our Facebook Live talk today on a very interesting topic, Gallstone disease. Allow me to introduce myself. My name is Noriana binti Muhammad Yusof. I'm currently an Operation Theatre Ward Manager in Assunta Hospital, and I'll be the moderator for this session today. Thank you for joining us today, and I hope you are all safe and well wherever you are during this COVID-19 pandemic. It's an absolute pleasure to have me today an esteemed and experienced speaker, Dr. and Surgeon Mr. MFS Krishnan, a consultant surgeon in Assunta Hospital. Mr. Krishnan is a surgeon for over 4 decades of surgical experience. He had his surgical training in the UK in the 70s and having worked there for 5 years. He ventured a diverse and enriching surgical experience in surgery when he worked in Lagos, Nigeria. This is before he started his work at University Hospital, Kuala Lumpur, now known as PPUM, as a lecturer and later associate professor in surgery, where he spent a good 10 years there. He started practice in Assunta Hospital in the 1990s, and from here he went overseas to acquire the skill for laparoscopic cholecystectomy. He and Mr. Liu Fakong together performed the first laparoscopic cholecystectomy in Assunta Hospital in 1990, which perhaps was the first in Malaysia. He has personally done over 600 laparoscopy cholecystectomy apart from numerous open cholecystectomy. He is here today to present to us some basic data regarding Gallstone disease, which is common in our society. So here a little reminder before I hand the next part of the session to our speaker. If you have any question during the talk, please feel free to type them into the comments box below this live stream. I'll bring the question up during the Q&A section, and they will be answered by our speaker. And also don't forget to like and share this live video with your friends and also your family so that they can also join us in this live session. Now, without further ado, I would like to welcome Mr. Krishnan to speak a topic of Gallstone disease. Please, Mr. Krishnan.
Good afternoon. I'm here going to speak today about Gallstone disease. I choose this topic because I have been seeing recently an increased incidence of Gallstone disease in our society. Gallstones occur in the gallbladder and also these problems can be related even to the biliary tree. The gallbladder is a pear-shaped organ that lies on the undersurface of the right lobe of the liver, as you see here, and it's about 7 to 12 centimeters in length, and its normal capacity is about 5 to 10 ml. The gallbladder is connected to the main biliary tree, as you see, which comes from the right and the left, and by a duct known as the cystic duct. And this duct then goes down behind the duodenum, that is the first part that comes after the stomach, and then enters into the pancreas gland, which is you see here, and along with the pancreatic duct, opens with a single opening in the second part of the duodenum. What is the function of the gallbladder? The gallbladder is a reservoir of bile. It also concentrates the bile and also secretes mucus. The concentration can be up to 5 to 10 times of the original bile that comes from the liver. The bile that is excreted by the liver is about 40 ml per hour, consists mainly of water, which is 97%, 1 to 2% of the bile salts, and about 1 pigment of cholesterol, pigments, and fatty acids. The flow of bile is controlled by an hormone known as cholecystokinin, which is released from the duodenum, and it is stimulated when the food reaches from the stomach into the duodenum. So whenever a person eats or takes food, there's an increased production of bile. Now, our topic is regarding gallstones. As you see here, that is a representation of gallbladder which has been diseased, which has been removed, and you see some gallstones that are here. They're multifaceted gallstones. This is an example of a mixed stones. Most of the gallstones are mixed stones. Other stones are cholesterol stones and pigment stones. A mixed stone is a combination of cholesterol stones, pigment stones, and some calcium salts. Now, why a very commonly asked question is, why do I get gallstones, doctor? The formation of gallstones are just explained here, as you see here. Cholesterol stones is here, then you have mixed stones here, and the pigment stones here. I'll start off with cholesterol stones. The cholesterol stones are usually due to an excess of cholesterol in the bile, and that occurs especially when you take a very high fat content in your diet, and which is commonly seen in the Western diet. It's also seen in persons who are obese. It's also increased in pregnancy, and a person who takes oral contraceptive tablets for a long period of time. Now, this cholesterol, when there's an increased incidence of cholesterol, flow of cholesterol in the bile, there could be crystallization of the cholesterol. This can occur when there's a reduction in the bile salt excretion, and sometimes it occurs in conditions like Crohn's disease, which is a chronic inflammatory disease of the intestines, or when the ileum, that is the terminal part of the small intestine, has been resected. The other factors that cause crystallization of the cholesterol are due to reduced nucleating factors in the bile, and also when the gallbladder does not function or empty properly. That means there's no contraction properly. It can also occur after some surgery, like when the vagus nerve is cut, when certain medications are given, like octreotide, for a long period of time. And when a person has a prolonged fasting, there again, the chances of crystallization of cholesterol can occur. Now, let's go to mixed stones, which is pigment stones. Then pigment stones are basically due to the pigments that occur in the bile. This is from the red blood cells. Red blood cells, have got a normal lifespan, which is about 120 days. And after that, these red cells are broken down, and then that pigment that is in the red cell goes to the liver, and then is converted into bile in the pigments. And this then if there is excess amount of that, then you can get pigment stone formation. And that is seen in patients who have got a condition known as hemolytic anemia. That means the red cells are broken down very rapidly and they become anemic, and that's why they develop pigment stones. The mixed stones are a combination of cholesterol stones and also pigment stones and some calcium salts. And this occurs due to bacterial colonization of the gallbladder. There's biliary conjugation and the pigment precipitation. So this will lead to growth of stones, along with the crystal formation, is the reason why mixed stones occur. Mixed stones form nearly about 97 to 98% of the gallstones that we see. The factors I mentioned as previously is that when the gallbladder does not function properly, that means it isn't empty, doesn't contract, then of course you tend to get stasis of the bile in the gallbladder, and that also can lead to stone formation. If the gallbladder is supersaturated, then again, you can get stone formation. As one ages, the chances of getting gallstones also increases. There's a gender preponderance. The female sex have a higher incidence of developing gallstones. And we seem to see that occurring in families. Sometimes when I ask my patients, the mother has gallstones, and she also has, or the sister has gallstones. So genetics do play a part. Again, genetics is, there are certain parts of the world where the gallstone formation is fairly high. One example is Chile in South America. Persons of obesity have got a higher chance of having gallstones. And the person having a high diet of fat, again, that's another factor. Women who have got multiple pregnancies, again, have got a high incidence. Whenever there is a rapid loss of weight, there's again a chance of developing gallstones. As mentioned earlier, oral contraceptive pills and hemolytic anemia are the other causes of gallstone formation. When a person has gallstones, he develops some symptoms. But when majority of these patients who have gallstones do not have symptoms, and they're known as silent gallstones. What are the symptoms of gallstone disease? Some of the symptoms, the chronic symptoms and acute symptoms. I'll deal with the chronic symptom, that means long-standing symptoms. They are usually patients who complain of bloating of the abdomen. They say, I'm belching a lot, doctor. After each meal, I go on belching a lot. There's flatness, my abdomen gets distended and feel very uncomfortable. The other thing is, of course, they have is moderate to mild abdominal discomfort, especially after fatty meals. Now, what are the acute conditions? That means acute conditions are when the patient gets biliary colic. When I mentioned biliary colic, this is the gallbladder, this is the bile duct, as you see here, and the bile duct, this is the duct that connecting the gallbladder to the main duct, which is here is known as the common bile duct. So what happens is when one of the stone comes to the neck of the gallbladder and blocks the gallbladder, the patient gets severe pain in the abdomen. And usually the pain is in the upper part of the abdomen, and they can get vomiting associated with that. And the pain will stay there as long as the stone is blocking this area of the gallbladder. If the stone slips back into the gallbladder, the pain subsides and the patient feels better. As and when it goes again, it can come back. So this is known as a biliary colic. So the other symptom is, some other symptoms can occur is acute pain with fever, and that is known as acute cholecystitis. That is infection in the gallbladder. So when there are gallstones in the gallbladder, there could be bacterial infection here, and that can result in infection of the wall of the gallbladder, resulting in a condition known as acute cholecystitis. Here, the patient has a painful right upper abdominal pain, which also, when on examination, you find on pressing the abdomen there's marked tenderness. The patient will have severe pain there. If the infection goes on and progresses further, then the gallbladder can be filled with pus. And when pus occurs, it's a condition known as empyema. Here, sometimes the gallbladder gets distended, full of pus, and then causes pressure on the wall of the gallbladder, thereby compromising the blood supply. Because when this sac is filled with pus and the whole thing can get distended maybe 2 or 3 times more in size, thereby what is causing this pressure on the wall, so the blood supply doesn't occur there, and then what happens, that becomes gangrenous. So you'll find black areas or patchy areas in the gallbladder, and we call gangrene of the gallbladder. And this can sometimes perforate, and the whole pus and the whole contents of the gallbladder is spilled over into the abdominal cavity, causing peritonitis. That means infection of the whole of the abdomen. It can also cause the bacteria and the septic material can enter into the bloodstream and cause a condition known as septic shock. Here, it's a very critical condition. The patient's blood pressure will fall and will be critically ill and has to be treated very vigorously. So this is acute cholecystitis, all related to the stone, as I mentioned, in the gallbladder causing acute infection. The next thing is the stone in the common bile duct. If the stone from the gallbladder moves and slips out into the main duct here, which is the common duct, then it can cause a blockage of this tube of the common bile duct, either partially or totally. Thereby, what happens is the pressure in the bile duct increases, so the back pressure is so high that the bile then enters into the bloodstream and the patient becomes jaundiced. There's also associated fever, and then the patient also has severe pain. So the typical features of this condition when there's a stone in the common bile duct is fever, jaundice, and pain. Sometimes if the stone acts like a ball valve, that means it goes up and down, there will be sometimes the pressure becomes less, bile can come down, and so the pain is relieved. But again, when the stone comes down, again it starts pain, fever, and jaundice will come. This is a typical feature of some patients who have this stone which goes up and down with intermittent fever, pain, and jaundice. And this condition is known as cholangitis. As mentioned here. Suppose the stone goes further down, then it can block. If the stone goes down or breaks up and goes down and comes down here and blocks the end part of the common bile duct, as you know, it shares a common pathway, that is the pancreatic gland and the common bile duct share a common pathway, and so the bile can then infected material and the bile can go into the pancreatic duct, triggering off a condition known as acute pancreatitis. And this condition, once triggered, can be quite severe. It can even go into severe pancreatitis, acute pancreatitis, causing hemorrhage or even collection of fluid around the pancreas, thereby can be quite critical and might need an intensive care treatment. Long-standing presence of stones in the gallbladder can cause irritation to the gallbladder and there's a chance of developing gallbladder cancer. Once you have diagnosed gallstones, what are the investigations that we do? The common investigation of blood tests, of which the most important is the liver function test. The liver function test is an array of few tests where you can test and see whether the patient has got a raised serum bilirubin, which is an indication that the patient has got jaundice, or there are certain enzymes in the liver that can be raised, which can tell you the status of the liver function, the liver cell function. The ideal test to find out whether there are stones in the gallbladder is an ultrasound of the abdomen, which has got a 90 to 95% specificity. So that is the benchmark of investigation for gallstone. A CT scan is only done when we suspect there could be associated problems like something in the liver or in the pancreas or in the duct, then we do a CT scan of the abdomen. It's not normally done in ordinary patients who have got gallstones. When is an MRI done? MRI, magnetic resonance imaging, is done when we want to delineate the bile duct. If we want to delineate the bile duct right inside the liver, outside the liver, right up down into here, MRI, and that investigation is known as magnetic MRCP, that is magnetic resonance cholangiopancreatogram. That will delineate the whole biliary tree and is very helpful to see whether there are any stones or any stricture or blockage. The next investigation is ERCP, is an endoscopic retrograde cholangiopancreatogram, which is an invasive procedure. Here, the doctor has to put a scope down into the stomach, which is a special scope, which has got a side view, which will come right up to this part and will locate where the opening of the common bile duct and the pancreatic duct is there. He puts a small wire into it and guides the wire up into the duct. Then he puts another tube in through that and injects a contrast medium and takes an X-ray to find out if are any stones, blockage, or stricture. He can also inject the contrast medium to delineate if there are any problems in the pancreatic duct as well. And this, apart from being a diagnostic procedure, is also a therapeutic procedure, because if there are stones or anything here, he can put a balloon inside and trawl the whole duct and remove whatever debris, stones or sand, and clear the duct. When he does that, he also makes a cut here into the opening, because this opening is the narrowest part of the common bile duct, and we call the procedure as sphincterotomy. So thereby you can allow the stone to slip out. Sometimes it might be difficult to remove certain stones which are high up. So then the doctor would put a stent in it, which is left there for about 6 to 8 weeks, which when the stent is there, the flow of bile is easier. And sometimes the stone also slips beside the side of the stent. And after evaluating about 6 or 8 weeks later, the stent can be removed through the scope. What do we do when we see a patient? As I mentioned earlier, about 50% of patients who have gallstones have no symptoms at all. In those patients, we just observe the patient and reassure the patient that we will just observe. Maybe if the patient has got any symptoms, he has to come earlier. Otherwise, in 6 months or 1 year, we will evaluate the status of the gallstone on a clinical examination, and if necessary, an ultrasound examination. What happens when you find a patient who has no symptoms due to gallstones? Then again, we will have to advise treatment, that is cholecystectomy, wherein the stone is large, which may be 3 centimeters or more, then definitely we will have to advise that the patient should have surgery. In children who have got stones, because they're going to have many years of their life further, we cannot leave it there. They also should undergo surgery. Young women who are going to get pregnant and have children who have gallstones should be advised to have the gallbladder and gallstones removed, because during pregnancy, getting complications relating to gallstones can really have adverse effect on the fetus. Diabetic patients, again with gallstones, we will have to advise that the patient should have a cholecystectomy, because the risk of developing infections and complications are higher. Patients who have got hemolytic anemia, that is where destruction of the red blood cells occur, again are advised to have a cholecystectomy, because otherwise there will be continuous formation of pigment stones. Patients who have got morbid obesity or very fat and who are going for bariatric surgery, they should have a cholecystectomy also done, because when there's weight reduction, there's a increased incidence of stone formation. People who work in the kitchen and in the catering business and who have gallstones and who are carriers of salmonella, that is the bacteria that causes typhoid, should have their gallbladder removed. It's a public health issue. Sometimes we find cholecystitis, that is inflammation of the gallbladder without stones, and this condition is known as acalculous cholecystitis. Patient gets typical symptoms of how a patient with gallstones would occur, that is pain in the upper right side of the abdomen, and then the gallbladder gets distended, the mucosa gets damaged, and there could be thrombosis, and we have to do an operation known as cholecystectomy. Having said this, very oftenly asked question is, doctor, can you give me some medicine to dissolve the stones? So now, the only thing that we do is sometimes very rarely done though nowadays, is using, if the patient has got a pure cholesterol stone, this has to be confirmed specifically by radiological measures and other investigations, and the patient has pure cholesterol stones, there is a possibility that you can take medications, but the process of dissolution is a long one. It might take about 2 to 3 years if to find these stones, cholesterol stones, fragmenting or becoming softer and then passing down into the common bile duct. But again here, once these stones go into the common bile duct, unless they go rapidly down the common bile duct, there's a possibility of blocking the common bile duct and creating problems. Other stones like mixed stones and pigment stones do not respond. There are no medications for that, and surgery has to be done. Often patients come and tell me, I'll come back in 6 months' time. They could resort to various methods like taking apple cider, white radish juice, and after 6 months or so, they come and say, can I have an ultrasound? So when we do an ultrasound, there's no change in the status. The next treatment is, the question they asked is, can we blast the stones? Because many people would have heard that stones in the kidney can be blasted and they do not remove the kidney for that. The stones in the gallbladder can be blasted, but then you're creating more problems. The stone will then fragment, go into the common bile duct and create blockage there. And that can create much more problem. The gallbladder, whenever stones are formed in the gallbladder, it's a non-functioning gallbladder. That's why you cannot keep a non-functioning gallbladder and just remove the stone, because the stones will reform within a year or two. Having said that, what's the treatment for gallstones? The treatment is removal of the gallbladder. The first cholecystectomy was done in 1882 by Johann Langenberg in Berlin in Germany. And the first keyhole surgery, what we call as laparoscopic cholecystectomy, was done in 1985 by Muhe in Germany. But it didn't catch up because the technology of the camera and the instruments were not refined, and it was not really practicable to do on a day-to-day basis. It's only in 1989 that it was really improved, the technology improved, camera system improved, the instrumentation was much better, and it took off. The first cholecystectomy was done in Assunta Hospital in 1990. Sometimes we do a procedure known as cholecystostomy. It's very rarely done. Cholecystostomy means we just make an opening into the gallbladder and remove the stones and the pus or the debris that is there. This is only indicated in patients who are very moribund, who are very sick and cannot stand general anesthesia, and we have to do a minimal invasive procedure. So we make a small incision into the abdomen, make a hole in the gallbladder, and then take out all the debris and put a tube. But now, with interventional radiology having improved, techniques have been improved, the radiologists are able to guide a catheter through the liver into the gallbladder and then drain the pus and whatever debris that is there. But however, the stones cannot be removed from the gallbladder through the intervention. But at least we can remove the pus and control the infection. And that is known as drainage of gallbladder, and that can we call it as cholecystostomy. Cholecystectomy means removing the gallbladder. And there are two methods. One is the open method, that's the traditional method that has been going on from the 1880. As you see here on the right side, an incision is made under the undersurface of the costal margin, and then it's exposed, and the gallbladder is then surgically removed and then taken out. And that's known as open cholecystectomy. Of course, now laparoscopic cholecystectomy has come into practice, much more advanced instruments, and the camera system resolution is so good that this has gained a lot of followers. But however, whenever we do a laparoscopic cholecystectomy, we have to advise the patient that when we put the camera inside and we find some anomaly or an anatomical variation, for example, and or if you think that the gallbladder is adherent to various structures like the small intestine, the large intestine, then, and we cannot safely remove it, we always have to do an open cholecystectomy and not continue with a laparoscopic cholecystectomy. I'm going to just show you diagrammatic representation how it is when we put the camera inside, we lift gallbladder up like that, and then dissect this area where the gallbladder comes and joins the main duct. And then, as you see, we clip the blood vessels that are going to the gallbladder, clip the cystic duct that is going to the main duct, and then we cut the cut the cystic duct, and dissect the gallbladder from the liver and place it in a bag and remove the gallbladder through the opening that is near the umbilicus or the navel. I mean to mention that outcome of the results following surgery depends on teamwork. And we in the Department of Surgery have a unique blend of surgical consultants who work in unison in the best interest of the person. The surgeon, apart being the leader of the team, leans for support from various other staff members, of which the main cog in the wheel are the staff in the operation theatre. They prepare the necessary instruments and equipment for surgery and know the specific requirements of each surgeon, which makes a lot of difference by itself. So, apart from that, I would conclude by adding a few words. Poor Diana, who is the moderator today, I'm privileged to have her here. She's one of them. She has now stepped into the leadership position and trains new staff in the operation theatre. We surgeons in the operation theatre miss her presence. And here is.
Thank you, Mr. Krishnan, for the interesting and informative talk. I've learned so much already about gallstone. Looks like there are quite a number of questions from our viewers. And so let's dive into the question. Shall we, Mr. Krishnan?
Yeah.
The first question, this is from Lydia. She asked, can we just remove the stone and leave the gallbladder alone?
I suppose you would have seen from my slide, talked here in the slide that I shared, that the gallbladder is an organ which is only a reservoir. And once stones are formed in the gallbladder, that function is lost. So you have a functionless gallbladder when you have stone in the gallbladder. And if you just remove the stone from the gallbladder, this gallbladder is going to make stones again within a period of 1 or 2 years. And that's why no surgeon would just say, remove the stone and leave the gallbladder.
We go to another question. This is from SP Chan, asking that, can the gallstone cause other severe sickness? Can stone, I mean the stone, the
severe sickness, yeah.
Cause the severe sickness?
Yes, gallstones can cause infection in the gallbladder, and the infection can then, as I said, if the gallbladder gets grossly distended because of infection, pus can form inside the gallbladder, and that pus can then cause a distension of the gallbladder, creating even gangrene and perforation of the gallbladder. Apart from that, also the infection can then enter into the bloodstream, causing septicemia, which can lead to shock. These are the severe problems. And finally, long-standing gallbladders there is a potential risk of developing cancer.
Before we go on to the next question, for all who are with us live today, you may still submit your question via the comment box below, and do keep the question coming. Yeah? We have earlier we have another question here, Mr. Krishnan. So we answer this question from Rachel Louis. Hi doctor, do gallstone pass through urine or stool?
The gallstones have no connection with the urinary system, so it does not go through the system. Of course, if the gallstone can slip through the duct, normally the stones just go through the stools. Very rarely will you find that a stone that is stuck to if the gallbladder, due to chronic infection, gets stuck to an intestine, there could be fistulization between the gallbladder and the intestine, and the stone can then enter into the intestine as well, which is a problem. It can block the intestine as well. Stone can grow in the intestine and produce a condition known as gallstonitis.
We actually do have another question from Lydia. What are the health problems caused by gallbladder removal after we remove the gallbladder?
Again, very commonly asked question by patients, what will happen to me when the gallbladder is removed? Again, gallbladder, as I mentioned, is an organ, a reservoir of bile. And once stone is formed, that function does not occur. So what happens to the bile? The bile then comes directly from the liver into the intestine. Over a period of time, the body then understands and really adjusts itself, and the bile will just come at the time from the liver into the intestine as and when the patient takes food. So the patient has no side effects of removing the gallbladder, a diseased gallbladder.
I think we answered another question, Ms. Krishnan. This is from Kiss. Gallstone can cause blood sugar to raise and cause permanent damage to pancreas, or it can be reversed.
The gallstone does not cause a raised blood sugar. However, gallstone disease, as I mentioned, the anatomy of the pancreas is very close to the bile duct system, and if stones do come down into the bile duct, and pancreatic duct shares the same opening, to exit in one stand, problems can occur due to stone, which can cause inflammation of the pancreas, and it's called as acute pancreatitis. Acute pancreatitis is a disease of the pancreas, and pancreas, of course, produces insulin as well. At the moment when the infection or when the pancreatitis is there, there could be a raised disorder of the blood sugar problem. So blood sugar can go up during the process. But most patients, once the acute pancreatitis is resolved, then the blood sugar control is maintained normal. However, if the patient develops a condition known as chronic pancreatitis, then of course it can affect the blood sugar control.
Okay. So there's another question here from Yak Lai Yin. Good afternoon, Mr. Krishnan. Will it cause the gallbladder rupture if gallstones problem leave untreated, like appendicitis?
Yes. As I mentioned, if the gallstone gets blocks the gallbladder, and then you get a condition known as, when it gets infected, we call it a condition known as empyema of the gallbladder. That means the gallbladder gets filled up with pus. And when the pus is there is a high risk of the gallbladder perforating.
All right. Okay, thank you, doctor, for the explanation. In interest of time, I'm afraid that we won't be able to address any more questions. Thank you for keeping the question coming, and we seek to answer the rest of the question. By replying to your comments box below later. Well, we have reached the end of our live talk today. Thank you once again to our speaker, Mr. Krishnan, for giving us an in-depth look into the gallstone and the modalities of the treatment. Thank you, all of you, for staying with us here today. throughout this session, and I hope you have benefited from the talk as much as I do. Stay safe and take care. Bye bye.
Thank you.
Thank you.